All right. Thank you, Shelby, for the kind introduction. Hopefully you all can see and hear me well. Just shoot us a message if you can't. But yes, my name is Jason Yeh. I'm one of the docs here at HFI, and tonight we're coming at you from our really pretty Memorial City office in the tower on the 13th floor. And I just want to spend a little time and talk to you guys about Fertility 101, all you wanted to know, but were too afraid to ask. So hopefully we can make this a little bit relatable, very easy to digest. Just shoot us a question through the question and answer submission form if you have something that comes up in the middle. But let's get started. So, perfect. So the first question that really, I think, before even patients even find themselves in the office would be to answer the question, when to see a specialist. And so, this whole process of infertility, it truly is, it's a lot more common than people realize. Most estimates these days are probably getting at about 1 in 6 couples, which is really, really frequent. 1 in 6 couples is enough that this is something that happens to a lot of people that friends, neighbors, and everybody. And so I think, there should not be any type of, unwillingness to go see a specialist just because this really is a common problem. But generally speaking, 6 to 12 months of trying should be enough for us to trigger an evaluation to seeing a doctor. Anybody who's got a history of irregular cycles or known reproductive problems, that can be a thing. So, if anyone's ever had like uterine surgery or ovarian cyst surgery, if anyone's ever had even like a ruptured appendicitis before, that's very common in childhood. A friend of mine actually just had that a couple weeks ago. But if that was something that is part of your medical history, then that might be something that could affect the ovaries and the tube. So not a bad idea to check in at least with your OBGYN and ask the question about whether or not you should see a fertility doc. So in addition to struggling with the actual pregnancy part, we see a lot of patients who struggle with multiple miscarriages. And so if someone's had 1, 2, or 3 losses and they're just really struggling to understand why, that's not a bad idea for them to see a doc as well. And then from a fertility preservation standpoint, this would be a smaller percentage of our overall consults, but this would include tougher cases where, maybe there's a family or someone struggling with a new cancer diagnosis, and the oncologist may have just, explained that the medicines or the radiation or whatever may damage fertility in some way or form. And so sometimes our discussions are to preserve someone's future fertility as well. And then also the other side of that might be, someone who hasn't partnered yet and may want to preserve a future chance fertility. And we do a lot of that. We call that elective egg freezing as well. Okay, so overview of fertility. Whenever we are asking the question, what might be the problem? Why is it so hard to get pregnant? I really try to break it down into a couple of buckets. And there are a few things that we really want to look at. And if we break it down into the most basic components, it really comes down to what you learn about in middle school biology and how pregnancy even starts. So that would include sperm testing, uterus testing, fallopian tube testing, testing of the ovaries and the eggs, and then just an assessment of general health and wellness. And the structure of this talk will just be a little bit of a discussion on each of these topics to explain how we go about testing these things. And I should say that when a couple shows for an evaluation, we actually recommend approaching all of these tests at the same time. I think a common question would be, do we stop when we find out there's something wrong and we check that thing and we decide, oh, this must be a uterus problem or a sperm problem? We focus all of our attention in that area. But in fact, a lot of couples who have the diagnosis of infertility, I would say 25 to even 30, 40% of people actually have more than one diagnosis. And we don't want to miss the forest for the trees here. We want to make sure we have a comprehensive assessment of everything. So sperm testing, that hopefully is pretty self-explanatory. A semen analysis is a collection of the sperm sample. This can happen at home and it can be brought to us. Typically we recommend that sample traveling no more than about an hour or 2 to the office for collection and analysis. We also have collection rooms at every HFI office that are private and comfortable, and that would be fine too. And when the sperm test results come out, it is an overview of numbers. It kind of looks like a math problem, honestly, which is not my favorite thing to like dive into the numbers necessarily, but it ends up being a lot of numbers and concentrations and percentages. But hopefully from that test, there's just a take-home message about, number one, what might the major problem be? Number two, is it modifiable? Is it actionable? Are there medications that can be taken? Are there procedures or anything that needs to be done? And then, number three, what's the next step? What do we do in terms of treatment? Do we do something less invasive, more invasive? Sometimes we even need to enlist the help of a reproductive urologic surgeon. So not to sound too extreme here, but that sperm test can make or break a lot of situations. And that there is I think a misunderstanding that if a couple is going through fertility treatment, there's a lot of curiosity about where might this issue be coming from. But in actuality, I would say even 40 to 50% of couples have some form of diagnosable sperm issue that should be investigated a little bit more. Okay, so let's move on. On the female side, we'll think of it anatomically as uterus testing, tubal testing, and ovarian testing. And this is uterus testing. And so this is a very broad overview, but basically speaking, uterine testing or uterus testing can be done with an ultrasound. And this would be like a pelvic or a transvaginal ultrasound. And it might seem kind of low tech, but in actuality, an ultrasound is by far and away the best way of looking at the uterus and the ovaries. We live in an age of crazy medical technology. We got MRIs, CT scans, functional MRIs, PET scans, all these crazy tests that can really image things to a really high level, but nothing beats an ultrasound where you can actually see real-time three-dimensional tissue structures, and actually even go as far as to count the numbers of resting eggs in both ovaries. And that tells us a lot about what kind of medications might be useful, what a person's future reproductive potential might be. And so transvaginal ultrasound, usually scheduled in the early phases of a woman's menstrual cycle, is one of the first tests that we recommend. The ultrasound, in cases where maybe someone does not have regular cycles, we don't have to be stuck with the idea of scanning and waiting, weeks or months for a cycle. We can actually perform the scan pretty much any time, and we use this ultrasound as one of our foundational tests, both in diagnosis and actually in treatment. Okay, the next test that we use to image a little bit of the uterus, but primarily a tubal assessment, would actually be something called a hysterosalpingogram. So this is a crazy word. I always tell my patients, like, the name of this is not important, but you can think of this as an X-ray of the uterus and the fallopian tubes. And it's basically a test where a little bit of fluid, it looks watery, it looks clear, but it's actually something called a radio-opaque iodine contrast. But the fancy way of saying that is the fluid that looks like it's solid on an X-ray machine, even though it's liquid. It goes into the uterus and the pressure builds a little bit and it shoots out the fallopian tubes, hopefully. So if you see in the image here, hopefully you can see my mouse, the uterus is filling, and then you can see these skinny little lines, and then a little spill happens on each side, and that tells us the fallopian tubes are open. This is actually a very, very helpful test to look at the tubes. It's a very common test. So we find that a lot of patients have actually had this done with their OBGYN physician, but the limitation of this test is that it's not an interventional test. If we find something that's wrong or just not quite perfect, or we can't explain what we're seeing, this is not a test where something can be done about it. So if we see maybe like a little pocket of something in the uterus, maybe it might represent a polyp or a fibroid. We just have to make some educated guesses for what that might be. If we see a fallopian tube that's blocked, early on or late or kind of swollen, those are all issues that, we can't really answer too well. We would have to pursue additional testing as well. The HSG, it is a very straightforward test. The other downside, and any quick Google search will come up with this. The other downside is that it might be a little uncomfortable for some people. In my experience, patients usually tolerate this really, really well. I think the average pain scale might be, this is from an observer's perspective, so I have not gone through this, but I try to be accurate with my counseling. Maybe like a 3 or a 4 out of a 10. That's what most patients will say that they've experienced. But, the fact of the matter is that some patients may feel a 7 or an 8, and that's understandable. Everyone's different. And for that reason, we actually offer and even sometimes recommend strongly the next assessment, which would be called a hysteroscopy and a tubal catheterization. So this is a highly specialized test. Uh, we perform this a lot, and it is what we consider in medicine the gold standard for testing. You know, a lot of times in medicine, there are 5 ways to attack the problem, and there might be one way that really stands far and above the best way to get something done. And for us, looking at the uterus, looking at the tubes, the hysteroscopy and tubal catheterization would be that. And so the way this works is a teeny tiny camera. It's about 5 millimeters in diameter. So I would say it's, you know, smaller than a typical straw in width. Goes inside the uterus. The uterus is filled with some water, and we're basically able to look around and inspect, just like you go into a room or walk into a house and inspect the walls a little bit. We can actually check the tubes very accurately as well. And this is actually done while the patient is sleeping. So it does require some anesthesia. So there's a little bit of inconvenience there of taking the day off and everything, but by far and away, it is a better test. The benefit also is that, you know, because you're sleeping, you're comfortable, you know, most patients are not feeling anything. If we see something that's just not quite right, either on as a first time diagnostic, you know, realization, like, oh, this is something we didn't realize was there, like a blocked tube or a polyp, or as a follow-up from an HSG or an ultrasound, those 2 tests that I mentioned before, the hysteroscopy can be used to intervene. And I tell patients about 95% of the time, we can fix whatever problems we have that day before a patient's even woken up. So by the time they do wake up, which is about 10 or 15 minutes after the procedure is done, and by the way, this procedure only takes about 5 or 10 minutes, we can usually say, hey, this is what we saw, and oh, by the way, it's taken care of. We shouldn't really have to worry about this again. All right, so that's the uterine evaluation. Another really big part of fertility testing is a real and honest discussion about the ovaries and the eggs. And so, you know, there are a lot of things about guys and girls that, you know, in my opinion, are just not, I don't know, maybe they're just not fair, if I could just say it that way. But a woman is actually born with all the eggs that she'll have. And so over time, the number does decrease. And even though you would think that all women sort of have a very similar age-related trajectory, that, you know, 30-year-olds have a certain number and 35-year-olds have a certain number, the reality is that that is not true. And some people at a certain age have much higher or much lower than expected egg quantities. This is not to say that they're more or less fertile. So there's a lot of nuance there in that discussion, but it does mean that they may respond very differently to certain types of fertility treatment. And we use that AMH level. There's actually a few ways of testing this. We can go into it, but we use that AMH level to guide us for counseling and to help us establish, you know, a bit of a time horizon. And for me, I tell patients it's a few things. It's number one, to understand, you know, what kind of situation we're in to establish a time horizon. Number two, to actually educate and inform patients about the probabilities of success with different interventions, because the AMH can help us educate people. And it is certainly one of my, let's say, professional passions of mine to make sure that we provide as much information as possible for patients to make like a really well-informed, educated decision about what they want to do next. And also to help us understand what types of medicines and what doses of medicines to use, because there is at some level a dose-dependent relationship between how much what medicine we use, if we have to use that, and what types of medicine. And we can learn a lot from, believe it or not, an AMH level. I don't think I mentioned the AMH level is a hormone test. It is a little molecule that is produced by the population of resting eggs in the ovary. And so when the AMH levels are high, it's kind of like a signal. Imagine all the ovaries or all the eggs in the ovary are just kind of, you know, shouting something or saying something. They're making some noise. And the louder the noise, the more we can guesstimate that maybe that resting population of eggs is higher or lower than expected. And that can be used to guide our counseling. Okay, so just to recap: sperm testing, uterus testing, tubal testing, and egg testing. That's the anatomic part, just kind of the nuts and bolts of fertility, everything you learn about in middle school. There are a lot of intangible aspects, not structural tests that also go into fertility testing as well. Number one, prenatal vitamins. It may seem a little bit obvious, but we do strongly recommend prenatal vitamins to be taken way before pregnancies even started. And so prenatal vitamins, I'm convinced that there may sort of be like a marketing gimmick amongst the vitamin manufacturers, but prenatal vitamins typically are just that has a minimum dosage of folic acid to about 400 micrograms. Most vitamin tablets will have 800 or 1,000 or 1,200 or wherever the case may be. You may even find some that are in the 2,000 to 5,000 range, but that qualifies you as a prenatal. But really, when you look at even men's vitamins, they have the folic acid supplement too. So it's like they probably just make one pill and shape it differently and stamp it. But at the end of the day, I tell patients to find the smallest prenatal vitamin they can find, because at some point no one's going to take a pill that's like the size of a I don't know, Monopoly dice or something. And so if you find something that's smaller, you're a little bit more likely to take it. Those vitamins will not actually increase fertility per se. What they're supposed to do is lower the chance of a birth defect, especially of the brain and the spinal cord, but they only work if you take it 3 months at least, generally before a pregnancy even starts. So it is a great effort to get pregnant and then start taking it, but in actuality, that actually might be too late. So prenatal vitamins before pregnancy, that would be best. Prenatal labs. So this is a general wellness panel. There's a lot that can go well with pregnancy, and unfortunately, there can be a lot that goes wrong. And some of these things are modifiable. There are truly medical conditions that can fly under the radar that can increase a person's risk of miscarriage or vitamin deficiency or gestational diabetes or all kinds of complications. And so if we get a handle on that before pregnancy even starts, in some ways we have an advantage over some OB offices where we love our OB colleagues, but they often get their first call when they're like, oh, we're pregnant, we're 7 weeks. And then the OB has to play catch up for all these health issues. If we find out these things beforehand, that can give us a huge advantage going into pregnancy. The third thing, we could talk about this topic for an hour, but I'll just kind of cover some highlights. Genetic carrier testing is basically this optional test, that's offered to people with the understanding that most pregnancies and most babies born today are perfectly healthy, but there is always this underlying level of risk of having a kiddo born with an inherited genetic problem. Typically these conditions, and I'm talking about the single gene disorders, things like sickle cell anemia, cystic fibrosis, spinal muscular atrophy. These are conditions that are extremely rare. I'm talking 1 in 2,000, 1 in 3,000, 4,000 live births. So they're very rare. Most couples will never have, that kind of risk. They'll never really, hear or see about this again. But the reality is that these conditions are very severe, and couples may want to get tested, meaning that we test the female partner and we look at those results. We only test the male partner in case there's a concern on the female side. And patients will say, I have no family history of this. The challenge is that people who are carriers of this disease or these diseases, these groups of diseases, they are asymptomatic, meaning that they have no signs, no symptoms of this. The only time that someone is, that we realize that someone is a genetic carrier is either through testing, and we find this out before a pregnancy, or during pregnancy, which raises some really tough questions about what's going on with the actual pregnancy. And then patients kind of have to navigate that, slightly scary path, or after delivery. And the pediatrician's like, oh my, this is a thing that we now have to worry about. So of those 3 options, we would prefer the first. And, not to get too far into details, but if we find out that a couple happens to be carrying, a condition on both sides, the male and female side, we have interventions that we can use to make sure that a couple conceives with an unaffected child. It does require some work. It does require some pretty advanced treatment, but it is possible. And we actually use this approach quite a bit for families that sometimes have already had a kiddo who's been affected. Okay. And then number 4, health concerns. Anything from, questions about weight or diabetes or, emotional wellness, history of miscarriages, ovarian cysts, metabolic issues, PCOS, smoking, like all of those can play a role in fertility. So that should be discussed as well. Okay, so that first part of the talk, that is what we call a treatment phase of the fertility experience. I really like to draw a mental line in the sand and have patients stop, and we all ask ourselves, what kind of issues are we dealing with? Let's investigate sperm, uterus, tubes, and eggs. We provide all the information we can. We have like a follow-up visit where we consolidate all our thoughts, and then we present the options. And the options will range from, plan A to plan Z. There are pros and cons of all of them. And our goal is to guide couples and patients through what treatment option might make the most sense. So I should also say that we do a lot of different treatments at a fertility clinic. There's, you name it, it's probably been done. But when you really boil it down to basics, you can think of it in 2 different categories. One is called IUI, one's called intrauterine insemination, and the other's called IVF. And so this next section will provide a little overview on each of those options. Okay, so IUI. IUI stands for intrauterine insemination. I like to make hopefully a polite joke and say that, I promise we don't use turkey basters, but for patients who kind of have the idea that maybe fertility clinics use a turkey baster, like this is probably what they're thinking about. But I promise it's a very small professional medical catheter. This should not be a painful procedure at all. But it can be broken down into 2 parts. Usually with an IUI cycle, even the name IUI, even though it doesn't suggest this, it typically includes 2 phases where there's an ovarian stimulation phase where we're using some type of medication. Either it could be pills, it might be a mixture of pills and shots, it could be injections by itself, but this will drive the ovarian egg development usually over about a week to 2 weeks time to grow a handful of eggs to ovulate. And then around the time of ovulation, we use a sperm sample and we prepare it specifically for an IUI process, and the IUI is done. So it might take, someone anywhere from 2 to 3 to 4 ultrasounds for us to make sure that the eggs have grown to a certain size. And then when it's time at HFI, we will schedule usually 2 IUI visits. The IUI itself, no anesthesia needed. I would liken it, of all the procedures that women have been through, if this has never been done before, it would probably be closest to a pap smear. Usually takes about 2 minutes, 3 minutes to do. Patients just kind of hang out in the room for about 10 minutes. There should be very minimal discomfort, and usually their partners, if that's the setup, the partners are usually there with them, and it's a pretty quick thing. And then, let me go back. And with the IUI option, the different medications, they have pros and cons. Each person's scenario will have specifics to their case, but there is a dose-dependent relationship between how much medicine is used and what the probability of success might be. And so that'll be a discussion unique to each patient. Okay. And then we can talk about IVF. IVF stands for in vitro fertilization. IVF has truly one of the most amazing sort of historical narratives of medical history. I mean, really, IVF is sort of a medical wonder child. I mean, it is something that was invented, 42 years ago, something like that. It really sort of came out of necessity. If you think 50 years ago, and this is actually my parents' generation, I'll share something personal about myself. My mother was actually adopted because the mother that raised her, my grandmother, was infertile. And, I have no idea what caused it, obviously, but even if it was something as simple as tubal factor infertility, right? If someone had tubal disease from something, 50 years ago, that was literally the end of someone's fertility. There was no way of conceiving at that point. Tubal surgery was not really effective. It's still not effective. And so it really was necessitated out of situations like that where, like let's start a pregnancy outside the body and then put it back into the uterus and we skip the tubes altogether. But IVF can be broken down into about 3 phases. The first phase is ovarian stimulation. So we use a lot of the similar types of medications to drive the ovarian function, to make them busy, to kind of get them hyperactivated. We watch this process under ultrasound. So we're very careful about making sure that the medications are dosed correctly and appropriately and at sufficient doses to make something happen. Usually after about 2 weeks, patients have to undergo a quick procedure called an egg retrieval. And the retrieval process, it is fast. It does require anesthesia. I will admit I have worked at other clinics, through my training years and all that, where I've seen this done with no anesthesia or very little. And it's just, I just don't think it's worth it. And it is safer from the doctor's perspective and the patient's perspective to be under anesthesia. So this is important. It's about a 5 to 10 minute procedure. And we're trying to get as many eggs as we can from those 2 weeks worth of stimulation. I will also add, it's very important to understand that we are not stealing eggs from the future. So the way a woman's body works is that these eggs per month, there's a certain population of eggs that's just available. And unfortunately, it's kind of a use it or lose it situation. If nothing happens that month, those eggs disappear and we're not really getting them back. So what IVF does, and to some extent IUI, is that we're rescuing as many of those eggs as possible, and we're doing an egg retrieval, and we're not stealing eggs from next month or next year. We're not hastening or bringing up the age of menopause in any way. So the egg retrieval is done. We get all these eggs out. I'll show you in the next slide what they look like. We add the sperm sample, and then over the course of about a week, the patient and I will get updated phone calls from the laboratory about how everything is going. And so we basically, the name of the game is to convert as many eggs into embryos as possible. And at some point, the embryos are frozen, typically. It's not shown in this slide, but they're usually frozen. And then at some point in the future, for most of our patients, it would be the next month, but it could be months or years later, an embryo transfer is done. And then we wait for a pregnancy after that point. So here's a little bit more of a scientific slide. I think the beauty of IVF, you can talk about this all day, and I definitely think the theory behind it is amazing, but what you see in front of you is the result of 40 years of immense scientific research, understanding, and breakthrough. Eggs. So this guy right here, that's a female human egg. And then after it's been fertilized, this is called a 2PN or 2-pronuclei stage, where you can see the genetic material in the embryo. So this would be a fertilized egg turned into a day 1 embryo. The single cell, thinking back to some high school biology, you got some mitosis action here, and then 2 goes to 4, 4 goes to 8, 16, 32, 64. And at some point, we hit a stage where it's called a blastocyst, or a day 5 or 6 embryo, where we're probably in the range of 300 to 400 cells. This embryo right here is tiny. I mean, we're talking 120 microns, that kind of thing. And then this little bump here, we call the inner cell mass. That is what hopefully and eventually turns into a baby. And then the rest of this is called the trophectoderm, which is just a fancy word for like placenta. And we take these embryos, we freeze them, even though it sounds extreme. We've basically realized through research and trial and error that freezing embryos, generally speaking, will pose statistical advantages, so higher rates of pregnancy and actually safer pregnancy outcomes. It sounds crazy, but maybe even lower rates of preterm labor and preeclampsia and gestational diabetes and ectopic pregnancies and all kinds of things that you wouldn't even equate to an embryo stage. Okay, I think we're nearing the end here. So in terms of PG testing, PGT, PGA testing, this is sort of like an extra step that some couples will end up choosing to do. It's basically a genetic test for embryos to see if embryos might be genetically normal or not before we do an embryo transfer. I mean, on paper, it sounds really great. And, I am still pro PGT or PGS or CCS. It goes by a bunch of different names. But, in general, this test is powerful. But as in, typical medical fashion, the more you learn about something, the more confusing it gets. And so we're understanding that this test is very powerful for women 37, 38 and above. And the utility for women 35 and under is questionable. I would not go as far as to say that it's not recommended, but we're starting to understand that we should be very thoughtful about using it in patients under the age of 35. So you can talk to your doc about that. But in theory, what PGTA does, and we see that it does do this, is it should increase success rates a bit per transfer. It should lower miscarriage rates. We also use it to learn as much as possible about an embryo so we feel really good about the embryo. So maybe we transfer one embryo confidently and we're not, putting in two or three kind of on a whim like the doctors and patients that came a generation before us, because in general, that can result into multiple pregnancies, which can cause all kinds of medical issues and complications as well. And then sort of as an extra little bonus, this testing can actually tell us about the gender of the embryo. It lets us know if the embryo is male or female. We cannot cause an embryo to be male or female, but if we have male or female embryos to choose from, patients may have that choice. They can choose to have that choice if they want. Some patients choose to learn about it. Some patients are like, no, don't tell me. Just, let's just go with whatever you think is right. And I'll actually ask the embryologist to make that determination. They'll just transfer the embryo that looks best to them. But if some patients have, an idea where they may be pursuing family balancing or something like that, or they just had in their mind that their first kiddo or second kiddo was going to be male or female, we can incorporate that into the treatment cycle.